in Portland, Oregon. And I did my fellowship year with Dr. Biggerstaff here. So I have done quality assurance on his images and him on mine.
Yeah, often a pretty good time reviewing your buddy's images. So I guess maybe we could just kind of start with how would you define quality assurance or QA, and who at your institution or sort of like in your in the groups in which you practice, who performs it, which providers are doing it?
I guess I can start. I mean, so um, we have so core ultrasound faculty do it. So we have we're like a really big program. So it's actually spread across three hospitals, and we have like six or seven core faculty. And so, I mean, but anyway, I mean, broadly defining like QA, QIs, essentially it's like expert level users review the images that are submitted by basically everybody else, look at them for both image quality and then sort of interpretive uh, correctness. We kind of break it up into, obviously it's a little different if you're talking about learners, and we break things down into sort of educational scans versus clinical scans. Um, so the feedback that is directed a little bit um, differently, but essentially that's the basic idea is that you essentially, all the scans done in one day in our department, somebody who is an expert looks through them, essentially make sure that people are um, interpreting them properly, and then when they are, when they're not, providing sort of focused feedback in terms of what was done not as well, what was done well, essentially what the error was, et cetera. And obviously sort of like the level of interaction with the user varies depending upon what the error was. If it's, well, we didn't, this was a blurry view or something, or you forgot to include, you didn't see all the kidney in a fast exam. That's different from like, hey, you did a fast exam and you said it was normal and there was a bunch of free fluid in the belly. It's like that kind of thing. Um, but yeah, so it's our ultra the way we divide it up, and we have a large program. We actually, like I said, three hospitals with all, so we have a large volume of scans. So we break it up. It gets done by the core faculty on sort of like on a rotating basis.
Nice. And I remember, so I came across Dr. Ehrman by reading a paper they'd published a few years ago in the journal Ultrasound and Medicine, where they talked about the agreement between the PIM fellows, ultrasound scans, and then their reviewers, the faculty, and in that there was a mention too of introducing the PIM fellows to doing quality assurance on each other's scans or reviewing each other's scans. Could you talk a little bit about that process and what it looks like?
Yeah, so you know, this is like a funny thing, which maybe a lot of people didn't realize, and I didn't realize it until I had been around long enough, is like the whole like behind the scenes ultrasound stuff is very like institution specific. There like aren't a lot of there's no sort of, ASAP, which is the American College of Emergency Physicians, that, sort of dictates is too strong a word, but has a lot of policy statements about like how different facets of emergency medicine should be practiced. And there is a policy statement regarding ultrasound. But that's just kind of this is what we think you should do. It's not like it's an edict. And so there's like so much institutional variability in terms of who does QA, how many like do all scans get QA'd? And I know you had a bunch of questions like kind of, and if I'm bleeding over, just let me know. But you know, uh, so who does it? How many? What proportion of scans done should be QA'd in what time frame, et cetera? There's like a huge amount of variability, and there's really no There's like no accepted standard. There's certainly, I think, a fair amount of consistency across like a certain level of sort of academic institutions. Like, ultrasound started, like at least EM ultrasound started as like a relatively small field, and so there's sort of still like a core number of people that were all like trained by one of the original people or trained in one, and so they kind of go to your programs and you do them in a consistent way. But as more and more fellowships popped up, it just became less and less um standardized. So going back to your original question, like in terms of like fellows doing QA, like absolutely, I think it's like an essential part of learning. When I was a resident, the fellows QA'd like not only fellow scans but resident scans and did a lot of it, and then the faculty did some amount of like overreading. But at our institution, it doesn't really happen that much. We try to like um get the fellows doing it sort of at the end of their fellowship year. But it's a little bit it's varied and it's not standardized. And the full disclosures, I'm ultrasound faculty, but I'm not one of the people that like I'm not fellowship administrator. I actually do more research now. And so I don't get to make that decision, but like I tried and tried and it just became, I don't know, if I guess it fell on deaf ears. And I'm not trying to denigrate my like colleagues or anything, but it's like absolutely, I think an essential part of becoming like a competent ultrasound user is that you not only look at your own scans, but you look at other people's, and that's how you learn image quality, subtle pathology, that kind of stuff.
Yeah, totally. We at OHSU where I did fellowship with Dr. Musgrave and we did a third fellow. We were all assigned each other's scans for the week. So we would have our weekly image review and would discuss the QA that we had done, and then like our the ultrasound faculty would overread kind of our interpretations and would select certain scans to talk about. And Dr. Musgrave, I know you're at a community internal medicine program. Can you talk a little bit about how you guys keep track of resident scans and the ways that you provide feedback?
Yeah, sure. I mean, I think it's a good contrast to what Dr. Ehrman was saying because we have a relatively small program right now. We have about like 15 residents per year, and then a group of faculty, most of which are not really avid POCUS users. So our volume of scans is much smaller. We also just recently got set up with a middleware kind of program, and I think that was one of the things we wanted to talk about today. I don't know if we can mention specific companies. There are several of them out there. Uh, but it's nice because the images don't go directly in packs for everyone to see, specifically when it's kind of a trainee that's doing it, and the reason for the exam is more for educational purposes and not necessarily for decision making purposes. Um, that said, when it's one of our faculty who is making decisions based on it and stuff like we also read those images as well.
And just for both of you too, and Paul, you can start with this one. Do you have sort of agreed upon standards? Is there like a document for certain types of exams where they have to meet certain criteria, or what does that like sort of grading process look like?
Yes. So what we've done is that like in these different middleware like kind of programs and stuff like that, you can set templates up. And what we are asking our users to do is after they do their scan, they fill out the kind of like worksheet, and that kind of tells us, what they thought they saw or didn't see and things like that. And that way we can kind of compare it to, what the images that were obtained. Um, Now, different scans are going to be, more complex than others. So, if it's just like a bladder or something like that, it's pretty simple. But if they're doing like a full cardiac exam or something like that, there's more elements to it.
Nice. Yeah, and I see Dr. Ehrman shared a link in the chat. Is that to the ASAP standards for the different
Yeah, yeah,
fees?
yeah,
Yeah.
yeah. And there's I don't I can't remember if it's in there. There's sort of an ASAP has also developed a sort of a image grading sheet template that I think many places use, at least many EM programs use. I mean, it's not super. It's like 1 through 5. It's like one is terrible. You can't see anything. Two is like I can sort of tell what you're looking at, but not enough to make an image. Three is like barely acceptable, and then up to 5. Um, yeah, I mean, so we have templates for each scan type. And it's sort of been like an evolving process for, depending on like what exam type you're doing. I mean, again, ASAP, and it's I think it's going to differ from subspecialty to subspecialty. There are sort of core modalities in EM that people are sort of expected to learn as part of like the training process. Like so, for example, like with Echo, it's like the 5 E's are the basic things like entry, exit, ejection, effusion, equality, which is like IVC, aortic root, EF, effusion, and then RV to LV ratio. And so the worksheets largely reflect what sort of the ASEP sort of recommendations are as far as um, like views you need to get and that sort of thing. It's is ultrasound has sort of expanded beyond some of these core things to more procedural stuff or even more niche is maybe too strong a word for like applications looking at like for like bowel obstruction for like bowel dilation. You can't make a worksheet for every single thing, so sometimes there's some like free text elements to it as well, but again, that's like an important part to me in terms of training. One is just sort of like standardization and making sure like everybody knows what the expectations are. Everyone knows what you're looking for. And then obviously on the back end from the QA side, like you want to make sure that people are, I mean, QA is like a very onerous process, and I would be lying if I know like literally a single person that enjoys doing it. Um, and so, trying to streamline it to make it as efficient as possible, I think is important. I mean, for example, like on a given day that I have to QA, there could be it's slower on the weekends, but sometimes there's like 60 scans in a day. Um, and so, you have to come up with a way to make it so you don't just like burn out and click through and like, oh, this is fine. So, make having worksheets are sort of like a living document in the sense that like you shouldn't be too dogmatic about what is or isn't on there, but it should be something that's sort of like designed, you have to find that balance between like making sure a learner it works for them. It's not too like onerous to click through all the boxes, but also that it captures the necessary information and then isn't like painful to review.
Yeah, for sure. It's I think there's a lot of agreement between specialties for some of the things that where there's, like we're doing cardiac scans and internal medicine and pediatrics and emergency medicine. We're looking for largely the same things typically, and so the guidance on what makes for an acceptable image is pretty comparable across disciplines. But there's other sources in the literature too. There was a paper that came out not too long ago. It was a Delphi study where they asked a bunch of it was mostly internists. I think there were some intensivists and some other folks that had gotten looped in there and asked them about like what made an image acceptable or ideal and what things should be included and that sort of stuff. So it's that stuff. I'm just bring that up to say that stuff is out there for different disciplines. And Kevin, you had a point or a question?
Yeah, regarding, that. that feedback portion of it. It sounds like you guys are using middleware, and that's kind of the way maybe communication. Is there ever a point where you sit down at some point, monthly, weekly, on some schedule, to do any of that feedback in person, or is it kind of like as long as you're meeting criteria for certain things, it's okay, and only again if there's like kind of gross like pathology that's missed, that there comes down to really more open discussions about that quality portion?
And just before either of you answer that question, I might just define middleware for us. So the middleware is also a word I had not heard prior to doing POCUS fellowship, and there are essentially like clouds or software landing spots for the saved images, the saved POCUS images to go prior to or en route to the PACS, which is generally like your hospital's image storage software. So the thing that like if you pulled up an X-ray and you clicked on the hyperlink to go actually like look at the X-ray images, right? That's your PACS, that radiology software where the images are kept. A middleware is another place for those images to be stored that also has often capabilities for image review and feedback, like what we're talking about with quality assurance. So they're often sort of stocked with worksheets, or you can build worksheets at your institution to make sure that the person who saved those images, they're going to do that sort of after they acquire the images and document their scan and make sure they hit on all the things that are important to you. And then that's also the place where someone can be notified that so many scans are ready, or maybe they have a sort of a rolling schedule where they do QA and they'll check in to see how many scans require quality assurance review, and then they'll input their feedback in written form generally. And then Kevin was, and that was a long long sidebar, but just to say so. And then Kevin was asking about what beyond sort of that written feedback, are there other mechanisms in place for you guys to talk with people in person, or situations where you would want to do more like one-on-one feedback or supervised scanning to make sure people are getting it?
Yeah, so I'll jump on first since my program is kind of less robust than Dr. Ehrman's. But so we um, meet with a group of kind of like interested residents who are on kind of like a POCUS tract. We meet with them once a month, usually on a Zoom session, and we kind of go through their images and stuff like that, and kind of do like QA with them of their scans. We bring up interesting cases or interesting findings, and so it's kind of just like a relaxed atmosphere for them to kind of learn on some of those elements as well. Now, the residents that aren't in that tract, it's mostly just remote feedback that will message them via the middleware software. But if it's something really egregious, like they were calling pericardial fusion that wasn't there or something like that, then I may reach out to them by text or something like that. Because we have a smaller program, I am able to kind of reach out to them individually, which may not be feasible with a much larger program.
Yeah, I mean, I think, sort of two sides of it is like from for learners, for residents, like absolutely meeting with them like one on one. We do that, and it's like it's a critical part of of learning. They get both, you know, directed feedback on their own scans, and then we try to do um, uh, something where you look at other people's scans. Like everyone who's on the ultrasound rotation in a particular month will like sit around, and then the fellows or the faculty will have pulled up some images, and everybody kind of goes through. Like that's an invaluable part of learning, I think. um, for um, for faculty, it's like an institutional dependent thing. Most of the feedback is via the middleware. So we use something called QPath, which essentially allows you to essentially everyone gets like an account, and you can you QA the scan, and then at the end, there's an opportunity to send the reports or like the worksheet with and the worksheet is split up in two ways. There's like um, the actual image interpretation worksheet that they fill out, and then there's like a QA portion of the worksheet, and you can attach that report, and it goes to their email and probably directly into their junk email because I don't think anybody looks at it. Or it varies. Um, we have a monthly like ultrasound division meeting where we look at like errors and review stuff. Um, if we, notice somebody that is like persistently, making the same mistake, we'll email them like serious errors. Like we try to do our QA within 24 hours, like something bad. If someone's like, there's no pericardial effusion, and there's a huge one, we call that attending. We try to in real time. I mean, we have like a medical record number, so you can like look um into the chart, and a lot of times like it's just bad documentation, and they'll have noticed that there was something, and the patient is like, you see they went to the OR, so then that's like less of an emergency. There's this is another thing where there's like a lot less standardization than I would have realized. It's just like credentialing and privileging is like at the hospital level. So it's like if your hospital says you can be privileged, then you can be privileged. Um, so, you can imagine, across EM, there's like super users and there's people that like rarely do it. Um, and we give this feedback, and it's like just the question becomes like, if you don't do it that often, you're not as good as it, and you're making all these errors. Should you really have privileges? Now that's like a totally different discussion. But there's feedback, at least from our in our program, kind of ranges from like simple emails to like um, anywhere to like we call you at home. And a lot of us do the QA like while we're working shifts, sort of in between seeing patients. So sometimes like I've been working overnight and I see a scan where there was some horrible pathology that wasn't noted, and I've called people in the middle of the night and be um, like you gotta fix this, or you gotta do like this should be addressed, like this is a big thing. Not that often, but I think that's like a crucial process is that there is some, at least whether at your institution, there's no standardized across institutional plan, but like you should have a plan about how you're going to find people and make them aware that something like terrible has happened or might happen.
Yeah, it's interesting you bring that up because I was thinking about this the other day, and I sort of wish I had invited some folks from the radiology world because that I'm sure it's a clinical experience people have had where an imaging exam is interpreted one way by maybe a resident, like a radiology resident, and then it's overread by the attending, and you get a phone call that like, no, there's like something significant on this, and just sort of hearing how they handle that too. Um, we we're in the process of sort of rolling out a more robust like credentialing process at University of Minnesota, and like doing like adopting a middleware. We're in like having these group meetings with representatives from these companies, and they're demoing the software for us, and we're having these committee meetings about what are the standards going to be and how many scans and all that stuff. And so it's just kind of an interesting place to be in, especially when you're talking to folks across different specialties. And I think also you had brought up this point too of there's kind of this difference between the quality assurance you're performing for people that are performing these images and providing clinical care, and people who are just trying to train and like learn how to do ultrasound. And maybe they're like we would call them educational scans, like residents come in and they're just looking to increase their numbers, and maybe they just get like volunteers that are hospitalized to allow them to practice obtaining some images. So um, I guess the lead into that then is are your focus primarily clinical exams like that are attached to an MRN and a case and all that, or is there a degree or an element of just sort of like practice exams that you're doing QA for? Not unlike some of the portfolio programs like through CHEST or SHM. they have de-identified data that's shared, and then it's purely technical. They're like, you've done it this way, and you should be doing it this way, whatever.
Well, I guess I'll start. If you're in my chair, I would say we QA all of the scans with equal, dedication, and whatnot. The, that's probably not true. I mean, we do strive to QA 100% of exams. We don't meet that. I actually, I'm the only person I think actually does all of my QA days, but that's like, neither here nor there. But just like it's a recognition that it's challenging now. Um, Clinical scans. So we have ours. Um, the way our middleware is set up, is there's an easy way to tell. So if you want to bill for a scan, um, you have to go through a number of steps. There has to be an order in the computer, and you have to have entered the patient's like medical record number into the ultrasound machine. And what happens is when those things have happened, it changes a column um, in QPath, our middleware, so you can tell that this is like a billable scan. Um, so those kind of get prioritized, at least by me. And I make the list and I do all of those. There is a radio button for clinical versus educational, but if you know something's not going to get billed, I try to hit billable scans first and then all the others. The username also shows up. So like I know who all the residents are, I know who all the fellows are. And then, someone I don't recognize is probably a student. And there's some like variation, like, students when they start out, the first couple of days, they're going to be doing a lot of scans and they're not like the best quality. So sometimes, you notice that like these scans, they're making the same mistake. And that, for me, it'll generate an email or I'll talk to someone, who the person that supervises the students and says like, hey, we need to talk to, such and such, like his scans are, his renal scans are not very good, or, he needs to work on this and that. So, um, but I think that trying to QA as many as possible is really best like for learners. I mean, when you have really engaged learners, right? Like people do better if they feel like somebody is engaged with their performance and their success and they have someone that's like looked through and says like, hey, this scan's really good. Where I think this scan could be better is by, doing something different. So we try to, and oftentimes that works better in like a face-to-face setting because that's just, I don't know. I think that's just the nature of how people respond to feedback. Um, but I do think it like improves people's like confidence if they can say, well, I did these 15 scans, someone looked at them, and they were just, judged to be okay, okay, like sufficient, like not deficient, if that makes sense. Like you want to know, like, I'm mostly doing okay, or am I like running off the rails? And again, so that's why I think the combination of like in-person feedback versus worksheet related stuff is complementary.
Yeah, for sure. I think the complaints we get the most frequently about feedback are that it's not timely, it's low quality, and they don't get enough of it. So you try to provide timely feedback in a way that is going to change practice, or at least encourage people who are interested and engaged. And it can be, like you mentioned, it can be tough sometimes when the scans pile up, the ones that you're meant to be reviewing. But yeah, that's um, uh, something we could probably talk about for a while. I might just turn the discussion over and see if there are more questions in the crowd, and then if folks feel like a lot of stuff has been answered, they can't think of any. I have a list of questions we can get to also.
I guess one of my questions is, did you always have protected time to do QA, or was it something you initially had to do and then kind of advocate for having protected time? And I guess how much time does it usually take you per week? And then if you have FTE for it, does it actually reflect how much time you spend on it?
So I'll jump in first. I don't have protected time for it. And the way I kind of justify it is that, like, the way our group works, we have part of our salary is tied to doing something that's associated with quality for the group. And so that's kind of how I am not doing this for free. It does take a lot of time. I'm trying to advocate for some of my time to be bought down, but even still, however much I get is not going to be enough. It is a very time consuming thing if you're doing it the right way and you're doing it well.
Yeah, I 100% agree. I mean, like whatever your buy down time is always some percentage that's like well under 100% in terms of the time you commit to it. I do get, I do get protected time for it. I mean, I have like some role in the ultrasound fel or is ultrasound faculty, and I get some yearly stipend that include, and one of those things is QA. I think it's pretty common that at least in EM that paid faculty, at least at like teaching institutions, have some buy down. Admittedly, I've never worked as outside of like an academic setting, so I'm not sure how it works with, like, I know there are like POCUS programs like in community hospitals. I don't know exactly how it works at those kinds of places. But it sort of it takes me less time now than it did when I started, but it's not yeah. It's like a pennies on the dollar kind of thing.
We we have a cool like uh, rural primary care pathway for our students at the University of Minnesota, and one of the EM providers got a grant to roll out this program for them where they get sort of longitudinal POCUS training throughout the year, and each of them is assigned a mentor. So I have three students that I am like their POCUS mentor, and I do their quality assurance for they each have a butterfly, and they have like we have access to that middleware, and we get paid per scan. So last year it was like for 30 QAs, we get an hour of, whatever the rate was negotiated through that grant. And this year I think it's like 20 because people complained they were spending like multiple hours trying to QA 30 scans. But that's another model I hadn't really come into contact with until helping out with this program, and it might be a way to sort of ease into it if you're having a hard time arguing for FTE.
Yeah,
Yeah, I
that's,
mean, sorry, go ahead.
no, I was just saying that's really interesting.
Oh yeah, yeah. No, that is an interesting. I wish I wish that was our model. Another thing, just in terms of like finding some way to get a bit, some remuneration for the time is just is billing, generating some revenues from these scans. I mean, like, I'm a firm believer that like it lets using point of care ultrasound lets you provide better patient care. And the billing as a whole beast in and of itself, but like some amount of collections for the hospital and for the physician group or whatever. I mean, that's a carrot that you can potentially use to get some like buy down. I mean, there's both like a facility fee that the facility, your hospital or whatever collects, and then there's like a professional fee, like with a lot of things. But so that's something that, again, that's a whole nother like entity to deal with, but that's something to think about.
Thank you.
And I just wanted to mention Dr. Liebner wrote a comment that their adult EM group meets weekly in person for POCUS quality review, and the residents lead the discussion with faculty commenting. I think that's a pretty common way for folks to do like image review stuff too. we during fellowship we had our like once weekly image review session with faculty where we would kind of walk through different scans and they would comment and then we it's a really valuable time for talking about the clinical integration piece too and how those images affected management, what you were looking for, that kind of thing. So thanks for that comment.
Was curious at any point. I know Rob, it sounds like you guys are pretty well set up, but maybe Paul, at any point, did you guys not have middleware and kind of had to do things around technology and kind of, I don't want to say old school, but like through some other, was it through Epic or RedCap to store stuff HIPAA compliant that might be more feasible for people who don't have that kind of capital or access to technology?
Yeah, so we got it set up with we our institution went with the Butterfly middleware cloud. Um, and before that, what we actually had was an educational grant for like the Butterfly's version of the cloud. Though the caveat with that is that we couldn't bill for those exams. Those were supposed to be only for educational use only. So when it was a situation where I needed to um, either get get something for my time for the scans. A lot of times what I would do if it was a problem with billing is that I would actually just add time. Like you can, at least in adult hospital medicine billing. I don't know if it's the same for peds, but you can bill for additional 15 minutes of time spent or something like that. So that's kind of how I would circumvent that process of it. But like the actual image storage and stuff like that, I mean, there were times where like we would be taking a we use Epic here. We would take an Epic clinical photo of the screen of the ultrasound and upload that into Epic. It was super janky, but like if there was something that I really needed to convey, that was kind of one of the only ways to do it. And it was ugly. It was a workaround, but kind of we made it happen. And I think that like if you're going to try to like do educational teaching and stuff like that, it would be really tough, I think, without some sort of middleware.
Yeah, I mean, I think when I started residency, we were um, printing out. We had like one of those printers on the machine, and you would print out the representative images and get tape from the secretary's desk and tape it to a blank progress note and put it in the paper chart. And for image review, we put things on a thumb drive, and there was even like the archival stuff was a VHS. There was VHS tapes. I remember in like the fellow office was just like boxes and boxes with like a year. So there used to be some like lower fi like middleware things where you could like I was a fellow at Cook County and there was like no money for the fellowship, and so we used some. I don't remember what it was called, but you'd take you'd put your exams on a thumb drive and you'd upload them to this like really like old timey interface that couldn't even take clips, and you'd type in your interpretation. So, I mean, there are probably some workarounds, but like you know, that's why, it's a perennial challenge is like capital investment from the hospital, the physician group, whomever, to say like why should I spend hundreds of thousands of dollars on all of this stuff? Yeah, that just, why? Like, how am I going to get my money back? And those are, fortunately, at least, and I respect you guys so much more for trying to like break into this outside of emergency medicine, because this was all kind of mostly started when I got in the field. But it's like other fields are now like going, like trying to surmount these same obstacles, which is like, yeah, why should I give you all this stuff, and pay you to learn how to use it and maintain it? Like show me where the benefit is. So, it's a it's hard. And I don't, yeah.
There's another provider I invited to join today who was unfortunately unable to come, but had shared some that they're at a hospital across town. It's a big kind of private health system called Health Partners, and they use an Epic integrated workflow. And then I just shared a paper it looks like pretty comparable to what they do across town at Health Partners, but they QA 10% of the exams that are performed on sort of a rolling basis. Um, and there's no middleware, so their images go directly to PACS from devices, interpretations done in Epic. And in the paper that I shared, it looks like they do that via procedure notes, so that there's an order for POCUS, and then you're doing a procedure note and then it's as soon as that's signed, that type of note notifies one of the QA folks who gets like a notification they're in basket to go and review that stuff. So there are ways around the middleware, but it's the middleware makes it all much more convenient. And it also makes it easier to like look at all the images performed by certain users. And that feedback process is a little bit more streamlined. We use like something like that Epic integrated workflow, at least for our procedure service. And we write a procedure note, and when we perform an ultrasound guided procedure, we save the images and then use the enter edit results tab on Epic in order to like provide an interpretation, like a read, and then that's sort of used for keeping track through Epic. But um, the yeah, I think most institutions that have like pretty well integrated programs do use a middleware.
And sometimes you have to be creative about the ways that you do get buy-in from your institutions. Particularly with internal medicine not being as robust as emergency medicine and things like that. Sometimes you have to look to EM and see kind of what they have in process. Actually, the way that we got in was we found out that our OB program already had a middleware set up, and we were like, "Hey, can like we jump on that?" And it was a 2 years in the making, but we eventually, we got on with them. So sometimes just got to be creative.
We so at our hospital, adult EM had it and then they shared it with PEM. But none of like the rest of pediatrics. And I think it's just because it's, more in like the last couple of years that other pediatric sections have been starting to use POCUS. And people individually were sort of asking about QPath. And then in the last month, just because we got together, like all the kind of POCUS champions from each section within pediatrics and called ourselves a group, that's when our chair was like, oh, okay, now I will pay for QPath for you guys. So it literally just took that and then they agreed to do it.
Yeah, I mean that's right. So, I mean, sometimes it's like little easy solutions, like getting enough people together and saying like, "Hey, help us." We're like, we're a group, and that was a great point about the like if EM has some of this stuff in place, like the infrastructure, like joining into that is substantially um easier. It's like less of a, it's like less costly. Like a lot of the stuff is in place, and like we're our like PEM is like fully integrated with our adult program now. We're starting to do stuff with critical care, internal medicine, and now even anesthesia um, wants in. And so I mentioned this just as sort of a way in terms of like there's potential ways to like defray the cost or sometimes like spread it around as saying like you know, uh, we like for PEM, we QA all their images and we get some yearly amount of money. And presumably as we start, and there's a couple of PEM attendings who were fellowship trained, and at some point, the idea was that they would take over the QA, although they don't actually want to. So now we just do it. But again, some of the ideas that like with these other, like as IM and critical care and anesthesia start using our middleware, they will start to shoulder some of the costs. At least that's the idea. And then again, it's sort of doubly beneficial because again, I think like you can't. I guess this is the wrong crowd to like preach about it. But it's like once you've started doing some of your own ultrasounds and you realize like what a difference it can make in patient care, it's like a no-brainer that this should be available. And going through all the safety features is important. But again, it's just it gets all the other people involved, and they kind of like, oh yeah, this is really great, and it defrays the cost, and it's like much easier. And in general, I think like EM people, ultrasound people are like a friendly bunch, and if outside departments say like, hey, we're interested. Can you help us learn? And, a lot of these people have fought the same battles. Like I would be very surprised to find that EM people were like not willing to like help individuals be champions and that kind of thing.
Yeah, I'll just read Dr. Liebmer's question here. Has anyone had issues convincing their hospital system to use a middleware system? Um, our hospital seems comfortable with the images being uploaded to PACS, but uncomfortable with the idea of it existing on some external cloud system. And I'm not sure if it's Butterfly related or the concept of middleware in general. I know in our search, I don't know that was really a sticking point. There's safety features to like all of those middlewares are HIPAA compliant, and it does depend a little bit the sort of the integration with your EHR. So it turns into a conversation that's had more so between the company and like your imaging services folks and your IT department on like the compatibility of certain products, but they're like they all meet requirements for like HIPAA compatibility.
Yeah, our IS department was briefly wigged out about it, but then, like Scott was saying, we had our people talked with the representative from the middleware, and they were able to assuage their concerns.
Yeah, my hospital system, which is separate from the university, is bonkers and actually insisted that our middleware um, instances run on their servers, like which, again, like QPAT, they're almost all HIPAA compliant but anyways, and so it adds layer upon layer of difficulty, and it makes it very clunky and hard to use, but it's I guess it was a surmountable problem, but this was a sticking point for us, like when we first started it, for reasons only, known only to the IT people or security people, but I guess it's surmountable, it sounds like.
I think for making contact with whoever the relevant decision makers are from IT and then connecting them with the representatives from the middleware, I think is maybe the way around that or right into it, I guess. We had like demos from companies and they could show us the features and from a clinical standpoint that was helpful, but like we don't understand sort of the ways that it's integrated on the back end into Epic and having people from IT there was really helpful to at least to like make the case to the folks who control the purse strings and make decisions about purchasing that kind of stuff. Cool. We're right up against 2 o'clock. Does anybody have any sort of pressing questions or things that didn't get answered? Things they just thought of? Nice. Well, I want to thank Dr. Ehrman and Dr. Musgrave so much for being here and giving us your time. We really appreciate the conversation, and I'll stop the recording now.